Hello, welcome everybody. My name is Michael O'Brien. I'm the president of Transcend Biologics, and I am excited to be joined today by our good friends at Transcend, Dr. Frank Johnson, joining us from Calgary, and Dr. Brett Cassio, who is joining us from Lake Charles, Louisiana. So how you doing, guys?
Good evening. Great.
Fabulous. Thanks for having me, man.
It's gonna be fun. So we're going to talk today. The title of the webinar is Ultrasound Guided PRP Protocol. So before we get kicked off, I want to introduce our speakers formally, as we just gave them a brief introduction. But Dr. Brett Cassio, as I said, is from Lake Charles, Louisiana. He's a board-certified orthopedic surgeon. He is also a distinguished retired or honorably discharged Army veteran, where he served as a lieutenant colonel. So, Dr. Cassio, thank you for serving. Board certified by the American Academy of Orthopedic Surgeons. He's also a specialty trained sports medicine physician, did a fellowship at Steadman Hawkins Clinic in Vail, and his residency at Johns Hopkins in Baltimore. So moving on, Dr. Frank Johnson. He is a family and sports medicine trained physician. He is a registered RMSK certified physician, which is the highest level of certification you can get for MSK ultrasound in North America. He was trained in the Caribbean and did a little bit more of his residency back in the God's country of Texas and Arkansas. And then he went on to do clinical rotations in England. So he's been all over the world as well. So one of the things that we want to do is, we're bringing people in from Sports Medicine Ultrasound, which is Dr. Johnson's company for training and education. And then we're also bringing in some of our customers from Transcend to this webinar. So we want to make sure we do a thorough introduction of ourselves. If you don't know us, we're headquartered in Dallas, Texas. The founders of Transcend came from another company called Eclipse, and we launched Eclipse PRP in North America in 2012. And we ended up growing that into one of the most widely used PRP collection devices in the United States, where we performed over 800,000 cases between 2012 and 2022. And so in 2022, we were acquired. And through that acquisition, we retained the rights to launch PRP, which is the same technology we've sold in the United States for 10 years, now 12, exclusively now in the orthopedic and sports medicine space. And so we are 100% focused as a company, contractually obligated and 100% focused on sports medicine and orthopedics. It's our passion. And we've partnered with companies like Masonic to merge our orthobiologics expertise with what we know is now necessary to get great outcomes in orthobiologics, which is ultrasound. And so Masonic is the brand we represent on the ultrasound side, but we're also a PRP company. And what we want to do is try to marry those two things together so that patients get the best possible outcomes, and physicians that are using our PRP products are getting better outcomes because they're hitting the target. And so if you don't know about our system, it's a very simple to use system. It's got a vacuum blood draw. We have a 22 ml tube or an 11 ml tube option. It's a simple centrifugation process, takes about 10 minutes. And then when you take the tube out of the centrifuge, there's an opportunity to decide what you want to do with it. What we recommend is you do a PPP extraction step. And by doing the PPP extraction, you can concentrate your platelets into a smaller volume of plasma and create your PRP. And so it's a gel separator technology. So it's separating out the red cells from the platelets in the plasma. And some people sort of associate gel technologies with lower volumes. But in reality, we package our kit up to a 66 or 88 ml kit, and you can decide, what you want your platelet dose to be. And we did some tests recently comparing it to some of the common 60 ml Buffy coat systems out there. And we're getting higher numbers in many cases per volume. In this case, a 66 ml draw produced 12 billion platelets in a 5 cc injection. So we want to make sure that people are associating gel separator technologies not just with single spin, low concentration, but actually have a low inflammation profile that is minimally, minimal inflammation, but also can be potentially high dose as well. So that's troponin cells in a nutshell. That's Transcend in a nutshell. What I want to announce now. By the way, if you want to request any of the platelet count validation, we know that there's plenty of companies out there claiming platelet counts. We have validated platelet counts, some peer-reviewed studies that you can request. So contact sales@transcendbiologics.com. We're happy to send those over to you. So at this point, just a little housekeeping. We're we're going to hand it over to Dr. Johnson and Dr. Cassio to go through the bulk of the presentation. If you have questions, if you go to the top of the Teams app, you'll see there's a chat. Don't use that. Go to next to that there's a Q&A tab. If you hit the Q&A button, you can click on that and it'll pull a little drop down on the side. And what you can do is start to put your questions, type those into the Q&A section while they're speaking. And when they close out the presentation, they'll move over to the Q&A and we'll have a dedicated Q&A session at the end. Okay. So I am going to pull this out, but before I do, I want to point this out. This is kind of cool. So we got Dr. Johnson up in Calgary, Alberta, Canada. We've got Dr. Cassio on the southern end of the North Atlantic or North American continent. And wouldn't you know, if you guys had a raft, you could team up. So Dr. Johnson, you could just hop in a raft on the Milk River, make your way over to the Missouri, find your way to the Mississippi, and before you know it, you're just a few miles away from Lake Charles. If you try to get to Dallas, I don't think you would fare so well where we're at. But anyway, I just thought that was funny. Connected by a large landmass, but still a waterway can connect you back together. So I'm going to click out of this and hand it over to you guys and let you take it from there.
So I'm a full-time clinician and a part-time educator. So I started a company called Sports Medicine Ultrasound, and we came up with a PRP training program. And protocols are at the heart of it. We are North America's youngest and most progressive MSK ultrasound training organization. You will be able to find on our website a free Learn to Scan course, a free Learn to Diagnose course, and a free Learn PRP course. So it's going to be available to you. There's no time limit, so don't go on that now. You got to stick with us and see Dr. Cassio's opinion. With Sport Medicine Ultrasound, we have run 50 live courses teaching docs, family docs, emerge docs, sport med docs, orthopedic surgeons, nurse practitioners, podiatrists, chiropractors, everybody to safely scan and inject. We have had an absolute blast. We've been all over Canada. We've started teaching in the States. We've taught at Dallas last month. We're going to be in Vegas later this year. So come join us if you want to learn how to scan and inject well and safely. Now, one of the things that troubles me is that people always say, my patients say, does PRP work or not? How long is PRP going to work for? And I say, well, hold on. We're scientists, and clinicians. We want to know, we want to collect some data about your symptoms. So when you have arm, shoulder, and hand pain, I think it's reasonable to ask your patient to fill out a quick dash. Dr. Cassio, if you unmute yourself there, do you have a favorite patient-reported outcome measure that you use for arm, shoulder, or hand?
Yeah, the quick dash is what I use. That's the quickest and easiest. So that's what we compare before and after for our patients.
Excellent. Now, the reason I think this is important because patients are going to come, and I don't know if you have the same experience, Brett, but I think patients come and say, hey, it didn't work. And I go, well, what do you mean? They say, well, I still have some pain in my rotator cuff tear when I do like a really, really hard pitch to my son. And I go, hold on. You weren't even taking out the garbage before, right? So unless we capture this data with a quick dash, a lot of times we're just going to miss it. Would you agree?
Absolutely. They forget how in what bad shape they were in prior to.
Okay, so I'm not going to spend too long on these, but I think for the hip arthritis, the IHOT 12 is a good one. There's like an IHOT 36. I think that's overkill. Do you use something like this, Brett?
The Harris Hip Score is kind of the old school one I use.
Okay.
Yeah.
Now, and Brett, how do you actually use this in clinic? Do you have like a mid-level, give it to the patient in the clinic prior to you seeing them, or is it something they fill out at home, or how does it work?
Yes, we have a research assistant that assists them to answer the questions. We just don't have a lot of luck with them doing it on their own online, although that's a standard way to do it. We just, in our population, we're not successful with that.
Got you. So if anybody's listening here saying, boy, I can't get my patients to fill out paperwork, it's not just us. Brett's hired a research assistant. But if you've got it built into your electronic medical record, it's better than nothing. Now, the next thing I have is the Womack. You know, this is up here in Canada. This is a gold standard. Wouldn't you agree?
Yes, would. Mhm.
Easy. Patellar tendon. So Melbourne, Australia came up. There's some researchers in Melbourne, Australia who came up with some really good tendon-based ones. So the Victorian Institute of Sport Australia -P patellar tendon one is a good one for patellar tendon. They also have a G for gluteal tendons. They have an A for Achilles tendon. Now, do you do any ankle and foot stuff? Do you use an FAOS score? What do you use?
Yeah, we do some ankle and foot stuff. We don't keep any scores for that. Just a visual pain scale is usually where we end off with that.
Now, my consent form is kind of exhaustive. Now, the reason I think this is important here, because we talk about informed consent, but I think informed consent, you know, you really have to talk about like what are the likelihood of some things. You know, I'll see consent forms that say you might have some mild pain during the injection and you might die, on the same line with a comma separating them. I don't know if that's the best way to do it. Do you have like a standard consent form that you do for PRP injections, Brett?
I don't. We actually just do verbal consent and document that we had verbal consent. So I used to have patients sign a consent for every injection in the office, and it just it was a lot of paperwork, and we didn't ever use it. So when I opened up my own practice, I tried to streamline and just did a verbal document that we had verbal consent.
Gotcha. So I've got two different consent forms I use. I have a longer one that describes the procedure. This was helpful for me at the beginning of my career. I've moved to a more streamlined one. I definitely want to make sure I ask questions. You know, I've got people before PRP treatments where they say, yes, I'm on blood thinners. I've just been put on high dose aspirin that I started 5 days ago. So, you know, I don't think that's going to, I want to consider that before doing a PRP treatment on them. Now, let's say somebody is driven in from 5 hours away and they've taken a baby aspirin for 2 days in a row. I'm probably not going to send them away. Do you have a way of handling that when you find out patients inadvertently taken an NSAID or an ASA, Brett?
It's similar to you. We're not going to cancel their plans if they come in from out of town and they've taken some NSAID. We just ask them to stop it. And aspirin, we don't, that doesn't bother me. Aspirin doesn't bother me for injections. So.
Excellent. Okay, so I think there are some PRP commandments before we move into specific body part injection protocols. So one of the things that has been out there in the literature for at least a decade is that you probably shouldn't be using lidocaine in high doses in the exact same area you're going to treat. So let's say supraspinatus tendon, you probably don't want to put a whole bunch of lidocaine into the supraspinatus tendon. However, it's been shown that ropivacaine does not affect PRP. Have you, incorporated this sort of, low dose lidocaine or no lidocaine in your practice?
Correct. We don't do any lidocaine or any canes at all with the injection. It's just pure PRP when we're doing our shots. So. And actually, people tolerate it pretty well. So,
okay. How about steroids? When somebody comes in and says, "Hey, I had a steroid injection in my knee," how long do you tell them you need to let it wash out before you do a PRP in their knee?
We do a 6-week break between a steroid injection into that joint and then our PRP, and likewise, vice versa. If they've had PRP, we wait 6 weeks if it's not working before we do a steroid. And then one more thing about I don't use a lidocaine or anything, but we do have a freezy spray for their skin to kind of freeze up their skin before we do the injection.
Gotcha. Thank you for that. Now, you mustn't use NSAIDs before or after. So again, ideally, if you can get your patients away from ASA, diclofenac, and naproxen a full week before and a full week after. And actually, when I say afterwards, I actually mean ideally you don't use it all for 3 months. But hey, you got a headache, go ahead and use it. Now, I'm not a stickler. Most of the people that I teach PRP to are near the beginning of their PRP journey. And most of them are not getting into complicated stuff like activating PRP and injecting like an activated gel. Are you using anything like calcium chloride or thrombin to activate PRP?
We are not, no.
So I think there's a time and a place for that in your career, but if you're just early in your career, don't worry about that. Now, I'm in a jurisdiction where cannabis is legal now, and there is a reasonable amount of evidence to say that CBD does sort of have an anti-inflammatory effect. So if you get your patients off CBD the same way as NSAIDs, warfarin comes up a lot, or these novel anticoagulants. My strong opinion is please don't stop warfarin or other anticoagulants. That's like, preventing a stroke or a clot, just for the sake of a PRP. Do you have an opinion on that, Brett?
Agree completely. You don't want to first do no harm. So I've injected plenty of patients on warfarin and other anticoagulants, and I haven't caused a hematoma or anything. I haven't seen one of those. So.
Excellent. And then there's also the question about efficacy is if they stay on something, is it going to stop them from having a good effect? So there's a few different things. Most of the anticoagulants are about, they kind of prevent platelet aggregation, but you get a lot of platelet growth factor release that has nothing to do with platelet aggregation. So I don't think it's a contraindication to a successful treatment. I also don't want to trigger so much pain the patient goes to the emergency room. I've done hyaluronic acid in hips or shoulders, or I've done PRP for, plantar fascia where the patient's, almost gone to the emergency room if I hadn't given them something strong. But that's my personal preference. Brett, do you have a standard go-to if you think they're going to have a painful reaction?
I have no problem giving them some if we're worried about that. Some Norco or Percocet, something like that. That's reasonable. Most of the people that have had the worst reactions and the most pain have been some of my buddies, my male friends that come in and get their injections. I haven't had any issues with females, just to throw that out there.
Okay. I don't think you should promise amazing results, and I do think you should wait sort of 3 to 6 months before determining success or failure, and that should be based on those patient-reported outcome measures. You just can't leave it to the patient to say it worked or it didn't. I don't think that's right. I also think you should optimize the patient's health before and after. I had one of the docs who teaches with me. He finally started doing PRP in his office, and he said, I think I'm going to get really tough with patients. I say, I want you to stop drinking alcohol. I want you for a week before, so no alcohol a week before, no cannabis a week before, get to bed at 10 o'clock every night, go for at least a 20-minute walk every day, and then come in for your PRP. And, and he kind of said, I think the patients started getting better results after I started doing that. Like it's just human nature. If you commit to your health, you're going to say, I think this is working, doc.
Absolutely. Lose 20 pounds, just stop smoking, all that. Yeah. They're all around better. So they're going to feel
For
better.
sure. Now, about pricing, I think a lot of sort of scientific webinars, we kind of forget that we got docs that are on the call that want real world advice about pricing. So in my clinic, we use 3 or 4 different kits. And if someone comes in and they say, look, I don't have a ton of money here. I can't afford the expensive top of the line kit. I say, great. Let's say your PRP is going to be $500. And they say, well, can you do both my tennis elbows? I'll say, sure. It'll be $500 times 1.25. Okay. So do you do sort of bundles with your patients? How do you charge them for your PRP?
So my flat rate is $1,500.
Okay.
For the 11 millimeter tube, 1 injection using ultrasound guidance. If they pay up front, it's $750. We don't do multiple joint discounts unless they ask and they seem like they're not going to. And I want to help them out. We might do a bundle. It just is an arbitrary thing, but usually it's just a cash discount if they pay up front.
Gotcha. So the patients that I have, I'll get patients, of course, I'll get patients that are, PRP curious and they just want to do one. But then I got patients that are like PRP evangelists and they say, hey, this works on everything. And I literally sometimes will have I've got these patients that come in from, some are in town and some come away from four hours away. And they give me a list. It's 5 spots on their cervical spine, 2 in their thoracic, 2 knees, 2 tennis elbows, and then there's always something else. So I don't feel like I can charge 1,500 plus 1,500 plus 1,500 plus 50. You know what I mean? So I want, when those patients are there and they want a bunch of body parts, I do come up with sort of a sort of bulk discounts, if you will.
Yeah, I think that's very reasonable, and I don't automatically say it's a 3 PRP series, although several patients have had PRP other places and they expect it to be a 3 PRP series. So there's nothing wrong with that. If I did that, I would probably consider giving a discount for all 3.
Great, thanks. Now, a lot of the challenge I have when teaching PRP to the docs who attend our courses is they say, well, how do I manage them afterwards? And I say, well, gosh, that's kind of sports medicine. And if you're in family medicine now and you're trying to dabble in, sports and tendons and knees and everything, yeah, that is quite a lot to learn. So I came up with this sort of chart. We have competitive athletes, whether they're university or, ones that are going to the Olympics, or we have professional football and hockey players up here in Calgary. And so I kind of came up with this way of thinking about it. You've got competitive athletes that are off season. Well, you can kind of do whatever you need to. You got ones that are preseason and maybe, might get, cut from the team if they need to take too much time off. And then you got ones that are in season. So I'm not going to spend too long on this, but I think it's very important to categorize your competitive athletes as off, pre, or in, and then small, medium, or big injuries. And I think this can help guide you. So Brett, let's say you got somebody who is an NCAA golfer. We were just talking about McNeese State. Let's say you got an NCAA golfer and they're in season and they got golfer's elbow. Number one, are you going to PRP somebody in season with golfer's elbow?
Absolutely. I do a lot of PRP in season and out of season now, but the biggest thing I see is labral tears and throwers. We're a big baseball town down here, but we'll do a PRP injection in season, and I ask them, how long can you take off? So we have that conversation before we give the injection. And if they say I can't take off at all, I'm going to say you're not going to get much benefit from this. You may want to just do a steroid shot. Maybe they've already had the steroid shot. So then they're determined to have the PRP and they can't take any time. I will, document that we suggest they would take 3 weeks off, but they can't. They're in season, and so we have to have some reasonable expectations of that injection. But we discuss that ahead of time before we do it, because we don't want to overpromise. I feel like I've never seen PRP do harm, and so I'm okay doing the injection, trying to get them some relief. I don't think I'm going to make them any worse. I think it's much better to do a PRP in season than to do a steroid in season, and they try to go back the next day or two and play. I think they absolutely can hurt themselves and make a tear bigger that way. So we have that discussion as well. So with tennis elbow and a golfer, I would invite them to strongly consider taking 3 tournaments off or 3 weeks off. But if they can't, they have to understand it may not do them as much good.
So that's interesting. You came up with 3, because I sort of arbitrarily came up with, I would call tennis elbow or golfer's elbow sort of a medium injury, in one of those. Whereas if it was like a football player, I would call tennis elbow like a small injury, right? So it's interesting you came up with 3 tournaments off, because I sort of arbitrarily came up with 4 weeks off explosive activities for a tendon. So that's neat that you and I kind of came up with that sort of 3 to 4 weeks, if you can.
And you have to really understand the sport that they're playing. So for instance, golf, I would let them go back and chip and putt within a few days, but not swing the driver necessarily for a little while. Same thing with baseball. They can swing one arm with the other arm, the good arm, do some one-handed drills, those kind of things. So, and they really appreciate you honing in on their exact situation, and then you develop a lot of trust that way with your athlete.
Excellent. And I do like that as well. So graduated returned activity. So not going to spend too much time on this slide, but I see a lot more, non-competitive athletes than I see competitive athletes. So same sort of thing, a physical worker with who's in normal work, they can't like baggage handlers. I'll see, baggage handlers at the local airport, and they can't take a ton of time off work unless it's a workplace injury. Then it's sort of a workers' compensation thing. So think about them as normal work where they can't take time off, or they got flexible work, or they're off work. But then the one I see the most, Brett, I see this more than anything. I see the retired people. And
Mhm.
then I got to figure out, look, is there a time pressure? Like, because you're going on a cycling trip through Spain, or is there no time pressure? Do you think about your retired folks sort of similarly?
Absolutely. You have to ask questions first and listen to them, and then match your treatment plan and your expectations to what they want. And I saw on your last slide talking about Achilles tendons. That's one of those ones that you're trying to get them back to work, and it's tempting to try to do some steroid around there, but you just don't do that. They're much better off getting some PRP than trying to do steroid around there, and put them in a boot, and then let the physical therapist wean them off the boot over a few days. And it is okay sometimes to say, look, your expectations are just not reasonable, and I don't think you should do anything, or go get another opinion, because I can't give you PRP and you go back and be in the strongman next week, strongman competition or something. So
I'm with you. So I hope this has been sort of a helpful way of thinking about, number one, how do you protocolize your patient-reported outcome measures to actually measure success or failure? How do you protocolize your post-injection management? So in our free PRP course, we also talk about like what's a sort of good way to run your staff through PRP training protocols. Now, just a little bit about PRP preparation. Not going to spend too long on this. Of course, we've got red blood cells and platelets mixed in with white blood cells. There's some systems that spin the blood really, really fast, and you get what's called a Buffy coat system. There are other systems that are sort of plasma-based systems, but it's super, super important to know that you can get a PRP that's sort of yellow, that has no white or red blood cells in it. And then there's a PRP that is quite concentrated, but there's usually a lot of white blood cells and red blood cells in it. So Brett, I'm going to put you on the spot here and say, intra-articular knee, hip, shoulder, do you inject more of a yellow PRP as part of your protocol, or do you inject more of sort of a white blood cell, red blood cell PRP, intra-articular and joints?
we use the same spin and look of the PRP. So it's an amber. We're looking for an amber look everywhere we're injecting it.
Gotcha.
Because look, in practice, I try to keep things simple. But if there is some pure data or really good data to show me one way or the other's better, I'll absolutely adopt it. But I also want to keep it more simple so my staff doesn't mess it up and give me yellow when I need red, or vice versa.
That's fair. That's right. Now, there's going to be some docs on the call that may have heard that yellow's for in joints and red is for tendons. I think I agree with you. I think that's kind of gone away a little bit. It's like, show me the data and I'll switch. But just know that, yeah, I'm with Brett. I think keep it easy. So how do platelets work? Well, we know this. So this was a slide I took from this website here, but this is sort of a standard sort of prolotherapy training and slide where we see that platelets, and this is standard healing in skin cells. Platelets do their job immediately. So I'm cutting myself and I get a nick. The platelets are done like very fast. They've done their job. They've triggered a healing cascade where inflammation goes out to about 7 to 10 days. Your body then proliferates new tissue, and then it remodels that new tissue over many dozens of days. So a lot of us say, well, I'm going to do a PRP treatment here, and then I'm going to protocolize my patient to come back around the 30-day or 45-day mark to revisit. Do you have a sort of protocol, Brett, for on average for when to see patients back?
We see them back in 3 weeks.
Okay.
and then at 6 weeks, because
So-
and that developed just over time, seeing when people were doing better or not. And so by 3 weeks, a lot of people are doing a lot better, and they don't want to wait to see me for 6 weeks because they want to go back and do what they wanted to do. And then some people at 3 weeks maybe weren't getting so much better, but by 6 weeks, we kind of felt like if I don't see significant improvement by 6 weeks, I can tell them, look, the PRP probably didn't do what it was supposed to do for you. Let's look at the next option.
Gotcha. Okay. Now, again, just to go back a little bit, I have had a lot of patients say, I really did turn the corner around 3 or 4 months, but like I definitely agree with Brett. Like most people aren't willing to wait 3 or 4 months and just see how it goes, right? So, I have a hematology analyzer in my office, so I've been able to test lots of different kits. So it's nice to see, for example, at baseline with this one system, forgive me, baseline with this one system, I had white blood cells that were 2.9, and with this one kit, one particular kit, the white blood cells increased a bit, but the platelets went from 171 at baseline up to 482. That equals about a 2.8 times. And so I love, the Tropicell system. I love that Michael was here presenting some of the recent validation data, testing what they're able to produce, because I want to see independent data. I want to see data from an analyzer. When I say independent, I mean from an analyzer showing me what's in the PRP that we produce. I met Michael in March of this year, and this is, I think, a unique gel tube system. When I say gel tube system, there's lots of gel tubes on the market. And what I really like about this is he's got a filter there, so none of the gel makes it into the treatment syringe. Most gel tube companies don't think about that. And they've also got a HEPA filter aspiration needle to go in there to allow you to draw out the blood. So if anybody's ever tried to draw blood out of a vacutainer, you're fighting against this sort of vacuum. And so to have this other air vent needle that allows you to have a continuous flow. I like that. I like that Transcend has online education. This is the biggest thing that I like out of this Transcend thing. What do I do if I get cloudy PRP? What do I do if there's something wrong with the gel? What do I do if I get like a pink PRP instead of it's more of an amber? Brett, are you nodding your head? Have you had any of these complications that happen? Like these happen with tubes.
Yeah. So I do what if all things being equal, I do what my staff likes and what's easy for them and what makes sense to them and where the best service is. So that being said, now I do have veto power, so I get to decide what system we're going to use. Now we've used a lot of them. This system had an obvious decrease in pain after injection because of the inflammatory process. It was just a less intense inflammatory process. So I noticed that. So I was very happy to try it and change. But my staff, like you're talking about, that the air valve, they love that, and it's just easy to use. And if they have questions, they have answers. They can find answers. So all in all, it's been, of the 5 or 6 systems we've used, it's been our favorite so far, which is why we're using it.
Excellent. That's great to hear. And similarly, I've used 5 or 6 systems over the years, and I think this is a nice, easy to use one that the staff love. There's another webinar on the Transcend website where Dr. Ryan Riggs talks about all the pros and cons in his mind. So feel free to go to the Transcend website after this webinar and find this and have a peek at it. So how do I counsel patients? Let's go. So essentially, I offer people sort of needle things before they come to my office. So Brett, if somebody comes to you and says, look, I've never done physical therapy, so I've got tennis elbow, never done physical therapy, I've never done physical therapy, never done any laser, never done anything else, I just want PRP. Do you offer it to them, or do you want them to do some other stuff first?
We will, because if the word of mouth and they trust their friend telling them it worked, especially if it's a healthcare worker that tells them it works. So I'm okay with that, but that's not the standard. The standard patient gets physical therapy, and a lot of times an MRI, and I have different theories on that. But basically, I don't want to be the person missing anything, so I order lots of MRIs. And I will send them to physical therapy and let them work on them. And 6 weeks later, I'll see them. And if they're ready for other modalities, we'll go from there. Now, some people come in extremis. Like say you have a worker that has tennis elbow so bad that he can't function at work. I'll give him a steroid shot. That's the example of someone I will give a steroid shot right then and there before I try other things. But all things being equal, if I have some time to work, I will send them to therapy, get them an MRI, and then tell them there are different options. I will mention PRP, I'll mention steroid, and then when they come back, we will usually go over their MRI, and if they can't get an MRI or they want an MRI, that's where ultrasound comes in. But then we will talk about their option. We'll do an option later after I've talked to them and let them think about it.
I like it. So that's actually a real good time to move into, and again, there's some contraindications and relative contraindications, but let me just get into, oh, sorry, I want to talk about evidence quickly. There's a company out there called Regenix that has done a good job of sort of pushing the FDA to allow us to do PRP in lots of different places. And at this link, you don't have to take you don't have to jot this down right now because this is included in our free course. I have permission to use this slide. So on the Regenix website, you literally get to click on this button here, and it takes you to this study about epicondylitis, PRP versus true and only anesthetics. So kudos to the Regenix people who are doing a lot of good work sort of advocating on the behalf of cellular therapies and also making that sort of advocacy based on good, solid evidence. So I just want to get right into sort of something you said there, Brett. You said, let me get to the tennis elbow one. You said that, so these are some of the protocols we're going to go through here briefly, but you said that if someone comes in extremis with tennis elbow, and let's say they had a visual analog scale score of like greater than 7 out of 10, I agree with you. I would put that as a suboptimal candidate to say at the least. And I will bounce them to cortisone. So I totally agree with you. So that sort of exclusion criteria is something that a lot of the docs who take our courses struggle with. Like, who do I know who to treat, and who do I know who to turn away and try something different other than PRP? So would you say for tennis elbow, a tear greater than 25% of the tendon might be a suboptimal candidate for tennis elbow PRP?
Yeah, I think if they have a significant tear, the steroid could make that worse. At some point, you have to protect the patient from themselves and try to get them out of the repetitive activity they're doing that's hurting themselves.
Right.
And hopefully they listen because but some people don't have that option. But remember to just document. Tell them you talked about your options. Very rarely will they go ahead and complete a tennis elbow partial tear to like a 100% tear by just pulling on it. Usually the pain gets so bad they can't complete that tear. Gotcha.
Excellent. So what I'm going to do now is I'm going to rip back to the beginning of this. So again, this is all in that free PRP course that you can have access to. So what we show you is essentially, so supraspinatus tendon, I have essentially for cortisone, hyaluronic acid, because I live in a jurisdiction up here in Canada where we have a hyaluronic acid that's optimized for soft tissue. It's available in Europe, it's available in South America, it's probably available in China and India, but it's the FDA hasn't approved it yet for prolotherapy, but we're going to focus on PRP. Brett, can you think of the earliest? So I've put in here as a protocol, I don't usually do PRP within the first 6 weeks of somebody saying, hey, my shoulder starts hurting, we scan them, and the only thing wrong is tendinosis or a small tear. Can you think of the earliest you've ever PRP'd somebody's supraspinatus tendon?
I would say 6 weeks is fine. That's that first, there's a significant chance they're going to heal that on their own. If they have even a small partial tear or tendinosis, interstitial tear, that's going to bleed a little bit, and they may heal themselves. So wait 6 weeks, I think, is reasonable in that situation.
Gotcha. So I think an optimal candidate is no tears as opposed to a suboptimal candidate. I'll get people in their 80s who have massive rotator cuff tears who are essentially the humerus is riding up against the acromion and they say, oh, I want PRP to try to regrow the tendon. And we just have to have an honest conversation with them about the limitations. So knowing there's an optimal candidate with no tears, would you agree a suboptimal candidate would be full thickness tear with retraction and just really crappy strength?
Absolutely. Some people want the PRP as a pain modality, and that's okay if you have that conversation with them. But PRP is not going to heal the tendon or bridge a gap once the tendon starts to retract.
Gotcha. You just said something there I want to pick up on. PRP is not going to heal the tendon. So the way I say it with my patients is I totally agree. It's not tissue glue. It's not going to bridge a gap. But then the patients will say, well, if it's not going to heal me, why would I do it? And I go, oh, geez, I think I just painted myself into a corner. How do you have that conversation with people when, let's say, something obvious like a tendon tear or meniscus tear?
So, when I say PRP, they're like, what's that? And I say platelet-rich plasma. And then they're like, well, what's that? And so I'm like, you ever cut yourself and look at your skin and there's a scab? That's your platelets making that scab. And in your body, it can do something similar where it can cause blood flow and then the tissues can heal. So I do kind of sell them on that. Maybe I am painting a little picture of a glue. I don't think that's the worst case scenario. I think the important thing is to make them not think that it's going to bridge a gap, or say they have a displaced meniscus tear. It may help the pain, but it's not going to heal that type of tear. Now, if they have a non-displaced linear tear, that the PRP may help that, especially if you can get it into the tear or really close to the tear. So that's how I try to put it in layman's terms for the patient.
Oh, I appreciate it. I've never actually thought about that. It's funny because I talk about like the shaving cut, but I've never actually said those words to a patient. So you've just taught me something else here today. That's great. So when it comes to anesthetic for the supraspinatus tendon, what I teach in my courses is it's okay to use a bit of ropivacaine in the skin and the deltoid. And if you do want to put a touch into the tendon, ropivacaine's been shown to be okay. What I do personally, especially the first time, if I think the patient's going to be pain sensitive, is I'll take 1 part lidocaine, so let's say 1 milliliter of lidocaine, and I'll mix it with 9 parts normal saline. So now I've taken my 1% lidocaine down to 0.1% lidocaine. So if I've got someone who's really pain sensitive, that's my way of kind of going, let me just get a little bit of anesthetic on board. But I've got other patients who I think can tolerate it just fine. Yeah, I don't use the anesthetic. I'm with you, Brett. So what would I do there? If I did want to do anesthetic, I'd use a 3 mil syringe, a 27 gauge. I'd put it into the skin, superficial to the tendon, consider a small amount into the tendon. I'll usually use a yellow, I call it a yellow PRP, or in Brett's case, just a touch of amber. I want to prepare 5 mils of PRP. Now, is the tendon going to hold 5 mils? Absolutely not. If you got a supraspinatus tendon without tears or even a small tear, you may only be able to get 1.5 or 2 mils of PRP into there. I saw a patient one time. I thought there was no tear at all. I put my needle in the middle of the supraspinatus tendon. As soon as I started to push, I saw the tendon open up like a book flap, the pages of a book flapping in the breeze. So if I didn't have 5 mils of PRP, I wouldn't have been able to fully treat where the tear is, along with the fibers anterior to it and posterior to it. So I do like having more PRP than I think I'm going to need. And I think a top tip is that, with supraspinatus or infraspinatus tear, the maximum you're going to do is probably 6 mils. And I think 3 milliliters is a common amount. I'm going to follow them up with a quick dash every month or so. For oral pain meds, I'll throw some acetaminophen plus minus tramadol or codeine. Now, immobilizing them. How frequently are you putting people in a sling that night, Brett? Because I know you see a lot of throwers. How often do you put them in a sling that night versus 2 nights versus 3 nights?
I usually don't use a sling at all. If they ask for one, I'll give them one. But I don't use it. Well, one of the reasons insurance usually wouldn't cover it, and then they only need it, if they would need it, it'd only be for a couple of days, if anything.
Yeah, I find people really struggle to get out of the office, go to the front and pay. And so that's like the awkward thing. So I think if you can get your patients to pay before the procedure, that's better for everybody.
Collect up front, no doubt.
For sure. Returning to activities of daily living. So small supraspinatus tendon tear, and they want to do a bit of gardening. Well, sorry. So let me back up. Can I comb my hair? Can I make a little bit of dinner tonight, Brett? I'm assuming that's going to be okay.
That is okay.
Return into gardening or something like that, give it some time, right? 2, 3, 4 days.
Yes, baby, it much as you
Okay.
can. Give me as much time as you can, and you're going to have a better result, is what I tell them.
Okay. So in a thrower, would you have them go back to physiotherapy in 2 days or 3 days?
Yeah, so it varies. Some people just need to be in therapy because they can't sit at home idle, but I will talk to the therapist about basically don't really do anything to them, just kind of sit them in the gym so they feel like they're doing something. But if they can just sit home and rest and let the biology work, that would be the best thing for them. If they are going to therapy, I really don't want them doing much for a week if possible.
Okay.
Then they start a throwing program, and then I kind of just turn them over to the therapist.
Excellent. So this sort of return to therapy about a week for the average person, okay, that works. And return to sport. Do you get involved in so you're an experienced orthopedic surgeon with helping throwers get back to sport. So for those on the call who are not experienced sport med docs, I think it's fair to say just discuss progress with the therapist. Is that fair?
Oh yeah, that's absolutely. You want to, we call it fill the boat, with as many heads as possible and opinions as possible, because if you don't want somebody to say, "Well, I told you so. He went too fast," or that she went too slow, or whatever. You just want to hear everybody's opinion. If the therapist asks my opinion, I'll give it. But otherwise, the therapist is the one that's watching them throw, looking for dyskinesis around the scapula. Basically, they can see if their shoulder's limping when they throw. I'm not there watching them throw at the 20 feet, then the 30 feet, then the 40 feet. So I have to trust the therapist and what they're good at.
Excellent. Okay, so let's move on to, so in our course, we show an example. So here's a bit of a slightly amber PRP. Shows, this is using a Clarius.
And there is European supraspinatus tendon. Really well tolerated. You do great. Thank you.
So the free PRP course shows examples of what it looks like to inject. One of the frustrating things with ultrasound is you can be set up perfect and still not see the needle, but at least we could see the fluid go into the tendon. Now, this is near and dear to your heart, Brett, glenohumeral joint. I haven't specifically taken a category for labral tears, but if we think about this, who do you think are the optimal candidates? Let's talk about throwers with labral tears, and then we'll talk about general population, 60 years old, maybe a degenerative labral tear. Who do you think is an optimal candidate as a thrower for with labral tear for PRP?
So the posterior superior peel off lesion labral tear is what we see mostly. And I think, in the throwing arm, I think they do very well. The tear just becomes, it needs a little help, essentially, is how I describe it to them. It's becoming detached. And then the other kind of analogy I use, it's like a hangnail. It's sitting in there when you're sitting around in class, but you go to throw and now it's peeling off to where the nerves are and you're feeling it. Your labrum just needs a little help. It needs to get it healed back down to that bone, and this can help you. And so we'll do the PRP coming in through the posterior approach, and then I really try to get those people to rest as much as possible. If they can give me 3 weeks, great. But again, in season, it is tough. But it comes down to basically your season shot anyway. Give me 3 weeks and you might get the rest of your season back. If you rush it, you're done. So sometimes it gets to be a hard decision or a conversation that way.
Can you think of a case or a few cases where you've injected somebody and avoided surgery with either a supraspinatus tear or a labral tear?
Yeah, absolutely. In fact, the long story short, I had a run at PRP 15 years ago. I had an older partner that was using it, and I was like, well, I want to do surgery. This is kind of dumb. And so I stopped doing it. And I really didn't revisit it until COVID, and nobody could have surgery. And then we actually were hit by a hurricane here, and nobody, even once we could do surgery, nobody wanted it because they were cleaning up their houses and stuff. So we went a year where everybody was denying surgery, just saying, we don't want surgery. What else do you have? And that's when I started using PRP. I became a believer. I saw it working, and I was like, I now joke sometimes, like, man, I'm going to put myself out of business. This PRP stuff works too good. So it's happened quite a bit. And are we talking just shoulder or the elbow too? Because I definitely want to touch on the Tommy John ligament if it's time to do that right now.
Yeah. So I didn't pull up the UCL stuff, but yeah, go ahead and tell me about that.
So you're saying whether I've prevented surgeries from happening? Absolutely, especially in partial tears of the Tommy John. And I didn't learn this in training or anything. I learned to actually do the Tommy John surgery, and then we had the Tommy John repair surgery. Well, the repair's 6 months out. The reconstruction is a year out of playing. So I started doing PRP and some partial tears, putting them in a brace for 6 weeks. I'm talking about a thrower, either a softball or baseball thrower. And my goodness, it works for me. It's been great. It's been really, really great. And I have not really had to operate on a lot of elbows. I mean, I think 30 or 40 of them, it's worked like a charm. And we're talking about at 5A level, high level, competitive high school baseball, and even college, it's worked. So I know it works, and it has saved surgeries from happening.
That's awesome. When we were chatting offline, so again, in the course, the demonstration of an injection, I don't actually have an injection of me, a demonstration of me injecting PRP into a GH joint. So I included one of me doing a hyaluronic acid. Before we started the webinar, Brett, you said something about you had seen a paper that said, hey, actually, there is an indication for PRP in frozen shoulder.
Yeah, it was a head-to-head comparison between PRP and steroid injections, and the PRP injections did better for adhesive capsulitis. So,
and
yeah, go ahead.
And was that a simple intra-articular posterior approach, or do you know if it was rotator or like a biceps approach?
Posterior approach, intra-articular.
Okay. Do you remember if it was like one injection or a couple?
It was one injection, one compared to one injection.
That's interesting, because when I made these slides, they went rarely used for this body part. So that's a neat one. I'll have to change that one. Common extensor, I use a ton for common extensor. The free course has a demonstration of me doing a video. So again, here's a touch of, this is the watered down anesthetic prior to the PRP. Hip joint. I see so many people who are in their 40s and 50s, and I'm like, man, I think you're gonna need a replacement. Like, it's breaking my heart. Like, you got any success stories with PRP and those sort of people that shouldn't be having a replacement, but you're not sure what else to do?
Yeah, the tweeners, where they have a labral tear, a little bit of cartilage changes on MRI, and basically I tell those patients, well, when we send them for their MRI, we send them to get contrast and a steroid shot. So when I get those patients back, they've already had their steroid. It's worn off. Now they're hurting. They want the next step. So in my practice, the algorithm is PRP next, then a hip scope, then a hip replacement. The PRP has worked very well for labral tears, from acute tears in younger patients, all the way up to degenerative tears in middle-aged patients. When you get to the older patients with arthritis and they're kind of a candidate for a total hip, I explain, just like with the knee, just like with the shoulder, PRP doesn't cure arthritis, but it can make the pain better and the function better. I think it's important to explain to the patient that you're not curing their arthritis with the PRP.
You know what I think I want to do? I want to go back and transcribe this whole talk, and I'm going to be like, man, you have said so many little pearls there that I'm going to start using in my office. So thank you so much for that contribution. Now, can you tell me a little bit about glute-med? Do you do much glute-med, glute-min? Because I see so much of this where they've got, it's either just bursitis, they've got these tiny little tears.
Yeah, it's the rotator cuff of the hip. So, basically everything that applies to the shoulder applies to the hip. I would be careful with doing steroid into the tendons of the glutes because they can tear. But I'll do bursitis injections, multiple steroid injections into the bursa. If they fail that or they just want to go right to PRP, it works great. I would say I'm happier with the results on the shoulder because it's not a weight-bearing joint, so you can rest your shoulder. It's a lot harder to rest the hip. Gotcha.
So we've got a few more minutes of the presentation. We're going to get to some Q&A just shortly, but I really want to ask Brett, are you using ultrasound to do your PRP into knee, or are you doing it good old-fashioned find the joint and do it blind?
We do both, and I like seeing it go in with the ultrasound. I was not taught in training to do ultrasound. I learned that after I've been out in practice, but you can see it going right where you want it to go. And it's interesting when I'm scoping a knee, I will always try to teach that some people have this plica in their knee that doesn't resorb. And what I tell the people that are watching and the students and stuff, the injection, if you're not watching the injection, you could put it up above the plica and it's never getting around into the knee. And maybe that happens in 5% or 10% of cases. So seeing it go where the injection go where you want it to go definitely is better than not.
I'm with you. Now, do you have a standard volume you inject? So you're using the Transcend system when you're doing a knee, moderate knee OA, degenerative meniscus tears. Are you using the 11 mil kit? Are you doing a 22 mil kit, 44 mil kit? What do you do?
I do 11 mil kit for basically all injections everywhere, and I get between 3, and I don't love if I only get 3 up to 5 or 6 cc's with that preparation.
Gotcha. So just so you know, Transcend does sell a 22 mil kit. That's the type of size that I like to have, because a lot of times I get asked to, can you do my knee and my CMC joint as well? And again, there's a fair amount of evidence to say that's coming out saying, if you can get in sort of 8 billion platelets, 10 billion platelets, and that would be like a 66 mil draw or an 88 mil draw, you may get some higher responders. So if anybody's watching and wondering, why is there an 11 mil kit and a 66 mil kit and 88? So, just to sort of follow the existing evidence. So just know that that's out there.
If patients in my office want 2 sites, we do 2 draws. So I guess it would be more efficient to do 1 bigger draw than 2 separate draws.
For sure. And then let me move on to meniscus tears. So I am on the board of directors of what's called the American Academy of Orthopedic Medicine. It's essentially sort of a prolotherapy training organization, then morphed into PRP. Now they do BMAC and they do adipose. When you're doing your meniscus, and so at our most recent conference in Florida, Joe Albano from Utah presented a little bit about treating meniscus tears. Now, Brett, do you actually try to get into the meniscus tear if there's like a radial tear, the medial aspect? Do you go into it, or do you just go into articular knee?
Well, if the person's skinny enough and we can get access to it, I'll try to get into where the tear is. Absolutely. That's ideal. Yes. So anatomy determines that, or adipose thickness, I guess, determines that a lot of times.
Gotcha. Now, I would say if you're watching and you're not a surgeon and you're near the beginning of your PRP career, I do think that getting just intra-articular is a great way to start. And then after you've been doing this year, 2, 3, 4 years, your ultrasound skills are starting to grow. You're starting to see who's responding, who's not. Then start start looking for the tears. But I don't think it's necessary to start there.
Yeah, and if you can find a patient with a parameniscal cyst, those are really cool and easier to see than just a tear of the meniscus.
Oh yeah, here let me show you on this one here. Right, so here's a dude with a big old parameniscal cyst. He wound up having this one debrided. This was an injection of cortisone. This wasn't a PRP, but I put it on there just for the ultrasound technique. So on the course, we're also going to go through quadriceps tendon. Again, this is the free course. We've got a demo of me doing patellar tendon for a young man, where this is the sort of yucky part of the patellar tendon down here. He took this like a real trooper. I thought he was going to be, not taking it well, but he was a champ. You'll see that on the video. Here's another one, just a plain tenotomy of the distal patellar tendon. Plantar fascia, have you done any plantar fascia PRP yet?
We did. Yes, I have. We did one just this week or last week. And the lady tolerated it very well. I thought they were going to crawl up the wall, but no, she tolerated it well and said thank you. And she'd been looking for something to help for a long time. So, yeah.
Fabulous. One thing I meant to ask you, and I've been forgetting this whole time, is, for a joint with PRP, what do you think's the worst that could happen? Like, are we talking like infection or big flare-up, or what would you say?
Yeah. Infection is the worst thing that can happen with injections, and that's a risk with any injection. It's very, very rare. As long as you're careful and you clean the skin, you should be fine. So that's the worst. I mean, you may get a little flare up. If you turn a partial tear, potentially they don't get better and the partial tear still hurts and they end up with a surgeon, well, they probably would have ended up there anyway. So you shouldn't feel fear that you're not going to make them better or it's going to keep hurting, because you were just trying to help and, first do no harm. So as long as you give a clean injection and there's no infection, then you should be in good shape and you're trying to help the patient out.
Now, I always struggle to know how to treat younger patients. So let's say, for example, this is the ultrasound scan of the younger patient I just had there, 17 years old. I never want to mess up mama's baby. But this kid had like a yucky tendon, because you're going to go in there and debride that, are you? Like if PRP isn't helpful?
Yeah, they're heading for surgery. So all you can do is try to help prevent and save them a surgery. So if you explain that to mom, she's going to love you. And if it doesn't work, well, you tried, and then they're going to end up with surgery, and they're going to forget that you ever even tried to not, to help them without having surgery. But yes, when you do surgery for that, you cut that stuff away, and I usually put an anchor in the patella and sew it back. And you could put PRP or amniotic allograft or some other kind of biologic, because that's a degenerative tendon, and you have to not just fix the mechanical tear, but the biology of what's going on right there. Basically, it's overuse, and somehow there's these micro tears that the angiogenesis just isn't keeping up with the damage that's happening.
Gotcha. Yeah, I'm always reassured when I know the worst that's going to happen is I might flare up their pain for a day or two, but they're going to chat with the surgeon anyway. He's going to do something that's pretty aggressive. Plantar fascia, Achilles tendon. I've done PRP on so many Achilles tendons. I still haven't figured out the perfect post PRP protocol, but I know the two options are put them in a boot, for about a week or two, or don't. What's your preference?
Yeah, definitely boot, or they're going to need crutches or a boot or both. And then I turn them over to the physical therapist and let them wean off till they're not limping. But they shouldn't walk out of your office limping. So they need some sort of modality to help them with that.
Excellent. So, and again, there's some videos of me doing those injections. You know, the course also has sort of a handout, you know, all those PDFs, all those proms, they're all in that free course. There's some stuff on this Wisconsin guideline for rehabs. So it's all in this free course. So feel free to access that. Uh, uh, Please don't forget that we categorize competitive workers preseason, in season, off season. Physical workers, no different. Retired athletes, non-athletes, retired patients. Do you have a time pressure or no time pressure? There's all the proms that are in the free course. And then, so thank you so much. Now we're going to get to a Q&A coming up here soon. If anybody has a jet, we appreciate your time, but we're going to do some Q&A now. But in your MSK journey from where you are now, the best way to get up to the mountaintop is to find people who are going there and to join them. And at Sports Medicine Ultrasound, we're headed up to the mountaintop. We got a bunch of awesome tutors with awesome experience. We want you to come join us up at the mountaintop. Either way, thanks for allowing us to be a small part of your journey. Thanks for Transcend for putting this on. And I can't wait to get to these questions.
We got a couple that came in. One of them says, PRP with surgical repair, will this help healing and recovery?
Yes. So, you know, a lot of problems are not just a mechanical problem. They're also a biological problem. So if you just fix the mechanical issue, the tendon tear, or remove the bone spur, those things, you know, the underlying biological problem is still there. The kind of the most studied thing is probably rotator cuff tears. You know, rotator cuff tears, you fix it, that one tears, another surgeon comes behind, the first surgeon fixes that one, it re-tears again. And so it's kind of the definition of insanity. Unless you change the biology, you're not going to get it to actually heal, because essentially most surgeons are all doing the same basic thing. So PRP works well in the OR. The trick is to keep it where you want it to go. So you have to drain out the scope fluid. If you're doing a scope or an open wound, you have to wash it, irrigate first, and then apply your PRP. I use a lot of amniotic tissue in the OR because it doesn't float away. It's a graft, and it stays right where I can sew it in and stays there. But yes, biology helps surgery and helps surgeons do better work.
That's maybe a kind of a segue to the top question here. It says, thoughts on activating PRP for partial tears where you wouldn't recommend PRP? Is there PRFM scaffold more appropriate for bridging the gap? So it's kind of what you're just describing. You wanted to stay put in the surgical setting, but you mentioned earlier you're not activating for normal ultrasound guided injections.
Yeah, correct. I'm not using any activation, and I'm just letting the platelets do the work.
Yeah, it's tough, you know, bridging the gaps. So, you know, I think that another way to say that is the tinier the gap, the easier it is to bridge. The other thing is the stronger the bridge, the better it works. So at our AAOM conference, we had a guy named Paul Tortland from Connecticut present some before and after cases of where he used MFAT or micronized fat to fill in a gap in a supraspinatus tendon. Of course, patient was in essentially a surgical sling for 2 weeks. But yeah, there is help with small tears of bridging the gap. But I don't think, you know, to the question, I don't think activating it is going to bridge the gap. You know, with high grade tears of the Achilles tendon, you got to get patients in this sort of Aquinas position, so the two ends of the tendon have a chance to come closer together. And with rotator cuff, that would essentially look something like this, you know. So it's just a hard body part to bridge a gap in.
Yeah, no doubt. As soon as that tear happens, the muscle just keeps trying to pull it 24/7. It's trying to pull the tendon edges away from its insertion site.
So bringing it back to the ultrasound training. So I see you got your free course set up there. There was a question about your Vegas course. Do you have information you can pull up real quick with information on that, Dr. Johnson?
I'd love to. Now, also, before I get to that, Michael, you know, part of the reason you and I started chatting was that you've got that WeSonic system. And I think the WeSonic Piloter is, you know, in my I use a Clarius, I use an Alpinion system in my office, I use two different Sonosite systems, and I have a GE. And we've had lots of different products available on the at our courses, including the WeSonic. And I think that WeSonic, the Pilar, does a great job of bridging the gap between the handhelds for about 4,000, but you only get one probe. And the Pilot does a great job of giving you two probes with a good price point. So while I'm pulling something up, maybe you want to chat about that.
Yeah, that's exactly where we put. If you're a team doc and you go out into the field and you want something that's powerful, that's got a good battery life, that's got better image quality than some of the Bluetooth systems would, project onto an iPad. When we did the Dallas course, we brought in a couple piloters, we brought our Navi system in, and the feedback from the trainees who are just getting used to looking at ultrasound for the first time, when they would hop from like the Bluetooth system to the piloter, was just, it's night and day. It's just so much more powerful. It's better image, but you are going to invest, an extra $15,000 typically to get into the piloter. We always say you're going to spend, if you buy a Bluetooth system, you're typically going to spend the money for the Bluetooth system plus what we are selling you, because you're going to want to upgrade eventually. So invest in it. We have financing if price point is an issue. But one thing is, he's pulling up this Vegas course. We had this idea now just to create some incentive for anybody on the call. And I'll let you do I'll leave it there at the end, but I'll show you guys. We have a special where it would be a $4,000 discount on our piloter system when bundled with our PRP system. And so we'll send you guys just detailed quote on that. This is going to live on the internet, so we don't want this special to run forever, but it'll expire on July 31st. So if you can get into that October course, you'll save $4,000, which I believe, Dr. Johnson, correct me if I'm wrong, is the cost of attending the course.
That's right. The 3-day course, including the 3rd day in the cadaver lab, which is happening October 4th to 6th. This October 26th, 27 is a level 3. It's a more advanced course, but the 4 to 6 is, I think it's $4,000 US.
So we have financing available if you want to do it this way, but we can do a full $4,000 rebate that you can apply towards CME training. We can't designate exactly what you do with that, so you would have to then go over to Sports Med Ultrasound and go purchase the course yourself. But we're willing to offer a $4,000 discount on our complete bundle package if it means that you guys will be able to get into the ultrasound course. And I can't speak highly enough about Dr. Johnson's course. The trainers that are there are super attentive and hands-on. Everybody that attended it had high praise because they got so much time on the machines. And it was like I was watching people really kind of learn, from experts in real time and see the light bulbs turn on. So for me, it was great to see you guys in action, so I can, confidently endorse everything that you're doing with these training courses, because they are excellent. So
our level 1 course, we on the first day we teach you 5 injections and make sure you do them well. Day 2, we add in another 5 injections. So you finish the weekend having had a ton of time on 10 injections. I think one of the mistakes I see with a lot of courses is trying to teach you too much. Another huge mistake I see with courses is they'll try to put 3 or 4 people around a single machine, and that is a huge mistake. You need a ton of time hands-on with the machine. So with our courses, we guarantee 1 machine for 2 people, and actually quite frequently have other machines that were sitting around being unused, because when you get 1 machine between 2 people, that's all your brain can handle. Whereas if you have 1 machine for 4 people, you're sitting around watch other people learn, just waiting for your turn, and it's just not enough. So please promise me, if you're going to do any courses out there, make sure you get an amazing 1 machine per 2 person ratio. And if it's not it, I think you're wasting your time and your money. That's my personal opinion. In our level 1, we teach 10 injections. In our level 2, we teach 25 injections. So what injections are those? So if I go on sportsmedus.com and sort of navigate to live courses and agendas, it's all here, what our top 5 are and what our top 25 are. And again, if you're an advanced user, we've even got a top 75 course. Brett, where did you learn your ultrasound skills?
Just kind of self-taught. So I just played around with the ultrasounds in the office, and I correlated the images with MRI and then in the OR. and so that's how I did it. I didn't know about these options for these great courses. I should have done them.
So, Michael, I don't have much else to share. What else? I know Arno asked you a question about the cost of the system.
Yeah. On pricing, so there's Canadian doctors on, there's maybe some international physicians on, there's US doctors, so different markets for different people. If you are from Canada or outside of the US, still please email us because we will connect you with the team that's out there operating those markets. But we're the American-based distributor for Wesonic and for the Tropicell system. We will be at the sports medicine ultrasound course in Vegas. And so if that's something you're thinking about attending, like we want to help you get in there in a way that's most cost effective. If you need technology, that's going to help because, as I mentioned, we're doing this $4,000 discount for a bundle package. So that includes 15 22 ml kits. It includes a centrifuge, a bunch of marketing. We have a doctor's marketing toolkit that comes with that. You saw some of the teachables, training information, and then you get a 5-year warranty on either your pilot or your Navi. So hopefully ultrasound technology by this point will be totally AI, and after 5 years, and we'll all just be we might be out of a job. But no, the Wesonic system, like I said, is just an excellent device. If it's a piloter, it's great if you're needing something that's portable. Navi system is just a little bit more single clinic, but it's super high powered, better image quality than piloter. So that's what we have. But we'd love to work with you guys, and if you can please just connect with us on LinkedIn, send an email to sales@transcendbiologics.com if you want more information on either Dr. Johnson's course or just do you want information on our products. We're happy to provide that for you. But yeah, it's 8:15 Central. Unless there's any more questions coming in, Dr. Cassio, that was super informative. I feel like I learned a ton just listening to you guys. Dr. Johnson, as always, love the enthusiasm you have for education and training other physicians, and looking forward to seeing you guys in Vegas.
All right, thank you.
Thank you so much. Now I'm happy to hang on a little bit. There's some other questions in the chat that I'll just address. I'll just address quickly, but anybody else has to go. Thanks so much for your time.
Yeah, we can do like a semi-close there, and if anybody else has any questions, we can keep popping them in.
For sure. Can we use local freezing mix with the PRP? So Sophiane asked that question. Absolutely. So again, Dr. Cassio doesn't. I use a 0.1% lidocaine. I talk about that in the free course. And then ropivacaine 0.2 or ropivacaine 0.5 is fine. However, from Dr. Cassio's experience, many patients do very, very well. I would say the areas that I definitely want to freeze up a little bit or anesthetize a little bit before injecting. Plantar fascia, absolutely. I think if you don't do it, you're gonna get punched in the face at some point in your career. I would say patellar tendon. When you inject somebody's patellar tendon with PRP, it feels like their knee's gonna explode. So if you can anesthetize at a touch, you're gonna make some friends. And yeah, I think those are the two that are the most difficult to tolerate. What do you think, Brett?
Yeah, absolutely. The plantar fascia injection is very painful. Yep, and sometimes the shoulder can be really painful too. There's a lot of nerves in the bursa.
Excellent.
This is totally off topic, but have you guys explored shockwave for plantar fasciitis?
I haven't. I've heard about it. I haven't done it.
From what I've seen, just patient experience wise, much more tolerable than an injection, and they do pretty well. So.
For sure, and one of my tutors is starting to do shockwave immediately prior to PRP, like literally prepping the tissue, prepping the patient. It's almost like shockwave's been proven to have like a post-shock. It's almost like a deep tissue massage. You do a deep tissue massage. As soon as they stop massaging you, you feel better, right? And so shockwave's the same. If you shockwave something and then PRP it, you may actually have less pain with the PRP than if you don't.
Well, it makes sense that you would trigger the wound healing cascade with the energy-based device before you enter that tissue with their own growth factors. So that's that makes sense.
I got a question from Craig Merrill 13 minutes ago. PRP treatment for treating Osgood-Schlatter. I would say the hard part is, well, most patients I see with Osgood-Schlatter are younger, so all of a sudden you run into that same question about you don't want to hurt mama's baby. I think almost all the time you got to back the patient off their activity level prior to attacking a 15-year-old's knee with PRP. But there was a paper looking at dextrose prolotherapy for Osgood-Schlatter that showed some reasonable results. I'm not aware of any papers looking at PRP for Osgood-Schlatter. So then we just have to go off script and say, all right, Brett, 15-year-old soccer player, Osgood-Schlatter, they've done no therapy. I'm going to say do therapy. They've done no shockwave. I'm going to do shockwave. And then it's still not getting any better. Then I'll PRP them. What's your protocol?
Yeah, well, first you have to remove the insult and put them in a brace. I was in a cast when I was 13, but you have to stop them from moving around. If you do that for 6 weeks, they almost definitely should be better. They may not be all the way better, but they should be significantly better. PRP isn't the worst thing in the world, but I wouldn't do that within the 6 weeks. I mean, I would make them fail immobilization first and therapy before I started trying to speed up the natural process.
The second group of Osgood-Schlatter I see is the ones that come back that are getting tendinopathy in their 40s and 50s. And so it's more like they have a patellar tendinopathy and you have to happen to find these sort of Osgood-Schlatter ossicles. So I hammer them with PRP for sure, and isometrics and negatives. Question from Shanice. Do you ever HA and PRP together same day? I only have a handful of patients where I PRP them and HA the same day. And those specific patients are going to be obvious, moderate to high grade arthritis in an ankle, a osteochondral lesion in an ankle or osteochondral lesion in a knee. And I just don't do it in other body parts. You, Brett?
Yeah, so we can really only use it in the knee, and I don't do it together. I don't feel problem with doing it together, but I just don't do it.
For sure, and I think there are some papers looking at combining them. I think the number of patients who are willing to pay for that is relatively small, and the evidence saying it's superior is also relatively small. So you're working on a niche within a niche.
Yeah.
Cool.
Is that all we got?
That's all we got. But Brett, I've learned a lot. Thank you so much for your time. Michael, as always, it's been great to hang out with you.
Thank you. Likewise, it's been great. Learned a lot.
Really enjoyed it. We'll have to schedule that rafting trip from Calgary down to Lake Charles for later. But
yeah, well, I'm definitely not going to paddle upstream. So
we'll come to you. We'll come to you. But hey, hopefully we'll see everybody in Vegas. Dr. Johnson, thank you so much for taking the time. Dr. Cassio, really appreciate it. It's been a really informative event. So.
All right. Y'all have a good night. Thank you.
All right. Take care.